Okay, in this video we're going to do some additional projections of the ankle and foot. Okay, so we have our ankle phantom here, and one of the additional projections of the ankle with a dorsiflex foot that this phantom is good for is the axial or half axial calcaneum. So what you do in this projection is to have the toes pointing straight up, so third toe straight up again. I think some books talk about doing this in a sort of half oblique position, but we won't do that for now. You ideally want the toes as dorsiflexed as possible, the ankle is in as much dorsiflexion as possible. This can be very hard when somebody's actually got a potential fracture of the calcaneum, because the tendocalcaneum or the Achilles tendon is going to be pulling on the calcaneum, because the gastrocnemius and soleus muscles are going to be under tension. So therefore, they're not going to want to pull their toes up and put that under tension. Then the receptor is put so that the point of the heel, the distalmost portion, is actually at the inferior edge of the receptor, because we're going to be putting an angle on the X-ray tube. Leave the marker off there for now. Okay, so variously described in several books as 45 degrees, 30 degrees, and sometimes as much as 50 degrees. So we're going to go to 45 degrees, and then we're going to drop this down and move this across. Now we want to get our central ray into the heel at a source image distance, reading the source image distance off here, of 100 centimeters. You can do it a shorter source image distance. Again, some books recommend a shorter source image distance to try and use the oblique rays to straighten out the position. Now, this is sometimes described as an axial calcaneum, but the receptor is actually in the coronal plane rather than the axial plane. So it should really be described as a half axial, because the X-ray beam is going from inferior to superior partly. So it's a infrosuperior projection, but the true axials are where the receptor is in an axial plane, and this isn't that, so it's called a half axial if you want to be totally correct about it. Okay, so I'm just going to keep going like this until I get the source image distance to 100 centimeters. Then the centering point should be really the middle of the calcaneum. So in this case, that's about there. And then we should collimate in. So that should be about right. It's not much space to get the marker on there, so I'm just going to pop it in the corner there. It shouldn't be in any way there. Good. Okay, I don't really know an exposure for an axial calcaneum here, but it's going to be a little bit more than a normal ankle. So I think I'm going to go for 60 and 4. Exposure button. Window this. So we haven't really got through the joint there. It's a lot of scatter here because there's a lot of density to go through, a lot of material to go through. But we've got a nice image of the posterior pole of the calcaneum. So what I could do is try this with a grid. So we'll change the receptor out for a receptor with a grid and position it in the same place, and we'll put a marker on the receptor in the same position. That's quite good. And here we go. So we'll try that. Now the exposure was about double what we needed, so I'm going to leave it as that because the grid should reduce the okay, so now because we've got the grid, because the grid is a technology that removes scatter photons. So the scattered photons were completely obscuring this area, part of the calcaneum, and now we've got that talocalcaneal joint starting to show up here. And if we window that a little bit more, we might get a little bit more detail in there. So this was definitely one of those extremity that could benefit from using some sort of scatter control, because there wasn't really much more collimation that we could achieve here. So we compare that with what we've got here in the Bontrager and Lampignano textbook. Then we've got a very similar looking image here. So it doesn't really give us any so saying the angulation might be increased if we can't get the toes up quite as high as they have. They're actually using a band to pull the toes higher to get more dorsiflexion. But as I say, if you've got a patient with a potential fractured calcaneum, that's not a good idea. So let's have a look. So yeah, so I approve of this plantodorsal, so it's a PD projection, half axial though, rather than axial, would be the ideal way of describing this. What's the angle that they're suggesting? 40 degrees. So we've used 45 and it's still probably not enough. I don't think 40 degrees would help. So that's the textbook description. What we'll try is we'll try turning it oblique and see what happens when we do an oblique. Okay, so if we turn the toes in, so we're doing more of a mortise projection. So we're looking at the position of the foot more in the mortise projection, and then see if that has a beneficial effect on the interpretation of that. Need a little bit more. 5.5, maybe 6. Okay, so I think we are getting hasn't really benefited a whole lot. Got the lateral, I think that's the lateral aspect of the head, the lateral fifth metatarsal is now overlapping a little bit. We could try the other way. If we slightly externally rotate, what happens? So we now see the metatarsal head is clear. You've got to be careful because this starts to look a bit like a fracture line here, when it isn't really. So imagine we're standing on the floor here rather than standing on the table, because the tables aren't really designed for people standing on them. They will not take the weight of an individual standing in one particular location on the table. So don't try this with a real patient, but with the phantom we can do this. So you would actually put the receptor on the floor and actually x-ray the patient, maybe holding on to the erect bucky, and then use the x-ray tube angling back towards the patient. Okay, so we get our patient stood on the receptor, like so. And we might need to just put it like so. And then what we do is we angle the x-ray tube 45 degrees. And angle from the back, so through the tendon, the calcaneus tendon or the Achilles tendon. You can imagine that one of the reasons why this isn't done is because if you're looking for a fracture or something like that, then obviously the patient's not going to be able to stand on their ankle. What you can do, of course, you could x-ray this patient prone. I'll show you what that might look like. If you've got the patient, it's possible you might be able to x-ray them prone. So you can see this is a true axial because the cassette is now in the axial plane of the patient, whereas the previous alternative was a half axial. And we need to rotate this round so that the yellow edge is at the distal end, and put the marker there on the lateral aspect still, and we'll see where we go with that. So we'll leave that as it is. Let's close that and see what. Okay, so we've got the same problem we had with the previous image with no grid. We can't really see because of the scatter. So eventually, these were the images with the grid. So let's just change the percent to 3%. Swap the yellow edge round to be distal and put a left marker on there. And expose that. So we can see that comparing that with the image that we got half axial, we just need to flip it round, I think, to get the similar comparison. So this is the difference. So we're comparing the ski jumper with the half axial. You get similar results.